Welcome to Next Round with the Pacific Research Institute. I'm your host, Rowena Ichon. If you've ever had a medical procedure and received a huge bill from your hospital because it turned out that one of your doctors was not in your insurance network, well, that's the subject of this podcast. Discussing surprise billing, yes, there's actually a name for it, is PRI Senior Fellow Wayne Winegarden, who recently authored a just-released study on this very subject. Tim and I, a PRI Senior Director of Communications, and I chat with Wayne about how it happens, why it happens, and what policy reforms can do to prevent it. Thanks for joining us. Welcome back to Next Round, Wayne.
Thanks for having me back. Always great to be here.
So we're so happy to have you here to talk about a big issue impacting patients in California and other states, surprise medical billing. Before we get started, paint the picture for us. What is surprise medical billing and how are patients impacted by it?
Surprise medical billing it impacts patients in a number of ways. I think the most troubling way and the way I emphasize in our latest report on this is when you go to a hospital for a procedure, whatever the case may be, and you make sure this is an in-network hospital and the facility's in-network and your primary doctor's in-network, so everything seems great. And then what happens to too many patients now is that even though they've gone to this in-network hospital and they have an in-network doctor, one of the doctors, often it's the anesthesiologist, is not in-network. So even though you as a patient, you believe you've done everything correct, all of a sudden after the procedure or after the surgery, whatever it is, you get this huge bill from your insurer because that anesthesiologist, they were out of network and we're only going to cover a very small portion of his very large cost. And so now you as a patient are responsible for that difference. Often these surprise bills is one of the kind of major impetus driving kind of this fear people have in terms of these bankrupting healthcare bills. And what makes it worse is it's a surprise.
Wayne, California and several other states have either enacted new laws or are considering action to protect patients from surprise medical billing. Your brief analyzes California's law, known as AB 72, which was enacted a few years ago. So what exactly are the provisions of AB 72?
Yeah, so AB 72 tries to directly address this problem, and it is undoubtedly a real problem that needs to be addressed. I think that's important to recognize right up front. The problem is AB 72 is price controls, and price controls, wherever they're tried, they make bad situations worse. Whether it's rent control, whatever the application of it is, price controls make the situation worse. In the case of AB 72, it gets complicated, but essentially what they're saying is if you as a patient are using an in-network hospital or an in-network healthcare facility, then any physician there, they have to accept one of two reimbursement rates, either the average insurance reimbursement rates based on their location, or 125% of the Medicare reimbursement rate. And so, like I said, so those price controls, the intention is to protect patients from surprise billing, but the problem, that's what we would want to emphasize, is that this is just the wrong way of doing it, and it makes things worse.
So what has been the unintended consequences of AB 72, Wayne? One has been, as you said, to reduce access to health care, especially in emergency rooms. What did your research find? How bad is the problem?
The problem is bad, and it's getting worse. And what's really concerning is it's going to continue to get worse as the dynamics, if you want to call it that, continue to mount over time. There's two, I think, troubling consequences from the bill, and it's basically anytime you have a price control, you're going to have these problems. If we go to rent control for a second, and I think this is an important parallel, because what happens with rent control markets like San Francisco is exactly what we see happening with AB 72. So if you look at the economic research on rent control, what you see is rent control, when you initially put it into effect, it just drives down the cost of rents for those people lucky enough to get the rent control apartments. And there seems to be a short-term benefit. What happens over time is that you don't get an expansion of the housing supply. You get a degradation of the housing supply. And so what eventually happens is prices go up even higher because of shortages, right? Growing demand as populations grow, restricted supply, you can figure out what's going to happen from there. Prices go up. So you actually make things less affordable, and the quality of the housing stock goes down. These are the exact consequences we're beginning to see beginnings of with respect to healthcare because of AB 72. If you look at some of the surveys, which is one of the best data sources we have this early on, what you see is survey respondents are saying, "I'm not going to be there for on-call at nights and weekends." The availability of emergency room physicians is going down. Contracting difficulties are going up. I mean, and it's by vast majority. Whether you're talking to physicians or the physician practices or other types of healthcare facilities, professional associations, hospitals, they're all saying the same thing, that the accessibility of healthcare is becoming more difficult in the state, and your availability of doctors when we need them, that is decreasing. Availability is decreasing, and so all of those kind of quality aspects of the healthcare system is going down, and then you have pressures on prices.
Wayne, another unintended consequence is that the law is pushing independent doctors and small physician groups to merge with larger hospitals and healthcare groups. You make the case that this consolidation is further reducing access to care, especially in rural and underserved communities. How so?
Well, the problem with consolidation, and there's a troubling trend of consolidation outside of AB 72, outside of California. But the problem with consolidation is that, one, it reduces your choices in the types of healthcare facilities you have access to. But it also becomes more expensive. Procedures that could be done in an outpatient, in a physician's office, inevitably are more expensive when that's connected to a hospital system. So that helps push up the cost of medicine. And when you see there's many studies that when they looked at what's the consequence of consolidation, it's that we're going to end up with more expensive healthcare than we should. So that obviously consolidation for logical reasons makes sense. It's this policy encouraged consolidation that we need to be concerned with. Well, what you have because of AB 72 is the state legislature has come in and it's completely unbalanced the negotiation between doctors and health insurance companies. And so essentially, right, if you're a healthcare company, you can say, hey, look, I'm going to wait out. This is my offer. I'm not going to budge. If you don't accept it, well, then I'll give you 125%. Well, I'll give you the average, and the average, since everybody else is on board, the average is going to be what I'm offering anyway. So you've essentially empowered one side of the negotiation compared to the other. And so that change in balance in power, what the advocates of AB 72 are assuming is that physicians aren't going to respond to that change in negotiation balance. And that's just a naive assumption. And what you actually see, which is what theory would predict, is that doctors and hospitals, and they're going to change. They're going to respond to the new policy environment. The way they respond, the way they rebalance the negotiation power is through consolidation. If they can become oligopoly, or in their sense, ideally a monopoly seller of the services, now all of a sudden they have leverage compared to the insurance companies, because they're, if you want to have an anesthesiologist, a certain whatever practices, you've got to come to this group. So if you get that local monopoly, you're going to be able to rebalance. But again, monopolies have consequences, and that's what we're beginning to see occur because of AB 72.
You also talk about AB 72 leading to reduced patient choices. Explain what you mean here.
Well, it's exactly what we just talked about in terms of monopolies, right? So that heavy regulations harm small providers relative to the large systems, and this is nothing. This is not unique to healthcare, right? When you look broader, we've done many studies looking at entrepreneurship and how do we make small businesses healthier. And one of the largest problems facing small businesses are regulations. Regulations disadvantage small businesses relative to the larger ones because they don't have the infrastructure to manage the burden or to negotiate, in this case, with the larger kind of these aren't competitors, but obviously they're the people who are actually paying the bill in this case. And so when we're doing that, we're now reducing the choice of patients. Patients don't have the option to see a provider that's not necessarily connected to the healthcare system. And in fact, since we're having doctor shortages, you also have reduced patient choice in terms of who they're able to see just in general. You have patient harm because with fewer doctors willing to be on call on weekends or at nights in these inconvenient times, again, because the price is just not worth it. Again, patients' quality is harmed because they don't have access to possibly to the right doctors at the right time. You can't always control, right, when you're going to have a health care incident or emergency. And so all of these regulations by reducing where you can be serviced or where you can receive healthcare services or the amount of people who are providing at a certain time, that creates a lot of concern in terms of the quality of healthcare that people will be given, or the fact that you have access to the doctors when you need access. And again, these are the effects that we're beginning to see, and it's growing over time. It's something that we need to head off before it becomes a real burden or start really becoming a large threat to people's health.
So, Wayne, in contrast with the big government approach in AB 72, you recommend several free market reforms that would help protect patients from surprise medical billing without imposing government price controls. So what are some of these reforms and how would they work?
Well, I wish I could take credit for coming up with them, but I think they're actually very, very straightforward, which is truth in advertising. Right? What we really need is to put both providers, insurance companies, hospitals, have them on an equal plane in terms of their negotiation power, and let them determine kind of what the right balance is in terms of payment. But from a patient perspective, if you go to an in-network facility, you should not be responsible for any out-of-network charges. That's it, and that's what I was talking about, truth in advertising. If a hospital says, I'm in your network, then that hospital needs to stand by that presentation to consumers. Right? And I can't imagine any other part of our economy where somebody can make that type of claim that they're in network and then kind of have a little asterisk in the fine print, that doesn't include and have this whole list. I mean, it's against our entire kind of freedom of information that those acts that apply across so many different industries, the financial industry. And so we need that type of structure when we talk about in-network facilities. So if a hospital is going to say they are in-network, there can be no out-of-network charges. And that, then again, if a hospital, they need to have anesthesiologists, the insurers have to be able to provide that service to their customers. So now it's up to them to negotiate what a fair compensation is. That will probably vary across the regions, but now we've put them in kind of responsible for dividing up kind of where those revenues are, and we've made them responsible for providing it, but we've taken that risk, which doesn't belong on the consumer, which shouldn't be on the consumer, and we've taken that away from them. And patients are protected, and the compensation is what the compensation is.
Finally, Wayne, as you know, surprise medical billing is a growing issue in Congress and other states. What's your advice to those who are looking at AB 72 as they work to address the issue at the federal level? Are there other more free market ways the federal government and other states should act to protect patients?
Absolutely. That AB 72 should not be the model. People are talking about these price controls. They make the situation worse. And I think that's something that we need to constantly remind people that, yes, surprise medical billing is a problem. There's also other aspects of surprise medical billing. When you go to an out-of-network facility, in terms of like for emergency care, there are often bills that can be associated with that. And we need to address those aspects of surprise medical billing. We've been really focusing on the in-network. That's what we focus on in the paper, that we focus on in this discussion, but we also need to address those issues. And again, it's the same type of protection for consumers. When you're buying insurance, we need insurance to be what we all believe it to be, covering those unexpected financial risks associated with getting sick, and have it the burden on the healthcare providers to provide those services in an equitable, efficient, and cost-effective manner. That type of free market approach can get us where we need to be when combined with, again, the truth in advertising advertising regulations upon them. But what we don't want is these mandates that either for the national level, if you imagine all of a sudden you had price controls on doctors, you're going to end up with the same type of doctor shortages that are plaguing the UK, that are plaguing Canada, and that is just the wrong way to go in terms of addressing this problem. I think one thing I also wanted to note is we also need to recognize, we're talking about more free market ways of addressing the surprise billing problem. I think it's also important to recognize where this problem came from, because the problem of narrow networks is something that really has come from the Obamacare exchanges, right? The ACA, Affordable Care Act. The mandates that have come along with the ACA has, in order to control costs, encouraged more and more insurance to become narrower and narrower. And it's one of the problems that you see with many of the insurance policies on the ACA exchanges, that you have these, in order to keep the costs and all the mandates and balance everything out and keep it affordable, you just get these inefficiently narrow networks. And this is why this problem of surprise billing is relatively new. It's evolved from all of these mandates. So something else that we need to really start thinking about is, well, how do we reduce those types of mandates so that you actually can have we'll return to broader health networks, because that is another important free market way of addressing the problem, which is allowing the insurance markets to serve their purposes, to provide kind of the insurance services for patients without all of the mandates, because we're kind of in effect tying their hands as well. And so it's important to recognize that the problem of surprise billing, that problem itself has come from previous government actions which have kind of interfered into the market, which have restrained the free market in order to achieve certain goals, which again, those haven't been achieved. And so we're getting that pile-on effect, which is, a problem created by policy intervention. So we need another policy intervention, creating more problems, and away we go.
Thanks so much, Wayne.
Thank you.
Thanks to my colleagues Wayne Winegarden and Tim Anaya. If you like this episode, please tell your friends and subscribe to PRI's podcast at iTunes, Google Play, Stitcher, TuneIn, and now iHeartRadio and Spotify. And when you're on these platforms, don't forget to give us a big 5 stars. If you don't subscribe to these platforms, you can still listen on PRI's YouTube page, youtube.com/Pacific Research 1. That's number 1. Thanks again. I'm Rowena Itchon. Hope you come back again for next round with PRI.